Rate versus rhythm control as a management strategy in atrial fibrillation has been a long-standing topic for debate. Though at one look, rhythm control would appear to be the ideal strategy, long-term adverse effects of the currently available medications for rhythm control is the often cited downside. AFFIRM and RACE trials were the main reason for the debate as they failed to show any benefit for the rhythm control strategy. AF-CHF trial in those with AF and congestive heart failure also failed to show any advantage for the rhythm control strategy. But there have been important criticisms as well. In AFFIRM, only 45% of the eligible patients were randomized to a rate versus rhythm control strategy. Nearly two-thirds in the rhythm control strategy were on amiodarone and only 14 had catheter ablation. Many were not in sinus rhythm or anticoagulated. It was the negative results of the trials that caused rhythm control strategy, which needs more skill in the use of antiarrhythmic drugs and can cause proarrhythmia or adverse effects, was relegated to the backstage. So it is clear that it was not rhythm control which was inferior, but the adverse effects of the currently available medications for rhythm control which was inferior. That is how the strategy of rhythm control by catheter ablation was thought of as a possible better strategy, though technically more challenging, not uniformly effective, and having significant risk of complications. CASTLE AF randomized 363 patients with atrial fibrillation and left ventricular ejection fraction of 35% or less, NYHA class 2 to 4 heart failure, and having an implanted defibrillator, to either catheter ablation or medical therapy with rate or rhythm control. The study documented that catheter ablation for AF in patients with heart failure was associated with a significantly lower rate of composite endpoint of death from any cause or hospitalization for worsening heart failure than medical therapy. Cabana trial randomized 2,204 patients with AF aged 65 years or more and those below 65 years with one or more risk factors for stroke, for catheter ablation with pulmonary vein ablation, or drug therapy with rate or rhythm control. Among the subjects of Cabana trial, 35% had NYHA class above 2 at baseline. Substudy of these patients with stable heart failure showed that catheter ablation produced clinically important improvements in survival, freedom from recurrence of AF, and quality of life relative to drug therapy. But the full cohort of the Cabana trial did not show a significant reduction in the primary composite endpoint of death, disabling stroke, serious bleeding, or cardiac arrest. The study authors noted that lower than expected event rate and treatment crossovers could have affected the results of the trial. East AF Net 4 trial had 2,789 patients with early atrial fibrillation and cardiovascular conditions. In the rhythm control arm, either drug therapy or catheter ablation could be used. The study was stopped for efficacy at the third interim analysis after a median 5.1 years of follow-up per patient. They concluded that early rhythm control therapy was associated with a lower risk of adverse cardiovascular outcomes than usual care among patients with early atrial fibrillation and cardiovascular conditions. Inclusion criteria were AF diagnosed within 12 months of enrollment, age above 75 years, previous transient ischemic attack or stroke, or those who had two of the following criteria: age above 65 years, female gender, heart failure, hypertension, diabetes mellitus, severe coronary artery disease, chronic kidney disease stage 3 or 4, Left ventricular hypertrophy defined as diastolic septal thickness of more than 15 millimeter. Overall, it appears that rhythm control strategy in AF may be better in those with heart failure and in those with associated cardiovascular conditions and early AF. In asymptomatic persons and in elderly with long-standing atrial fibrillation and markedly enlarged left atria, rhythm control strategy may not be ideal. Though rate control strategy could be with beta blockers and calcium channel blockers, latter are better avoided in those with heart failure.